I think we can all agree that time is a valued commodity, so making the most of the time we spend in office visit is key. Dr. Doug Devries will be joining us today to discuss the benefits of comprehensive, collaborative care to both the patients and practice. Dr. Devries?
I want to talk to you.
Not now, later.
No, now.
So welcome to OCuTALK. Today we're going to be talking with Dr. Doug Devries of the Eye Care Associates of Nevada. Dr. Devries, thank you for being with us.
Absolutely. Thank you. I appreciate being with you today.
So Dr. Devries, obviously you're very well known in the eye care community, but there might be some people on our channel that aren't familiar with you. So could you take a minute and just tell us a little bit about yourself?
Yeah, absolutely. I co-founded Eye Care Associates of Nevada really almost 30 years ago. And the whole concept was a unique concept that we were forming this practice. We were bringing ODs and MDs together to provide a continuity of care and support and work with the optometric community to promote scope of practice. So 30 years ago when that was happening, it certainly caused a little bit of controversy. And as it is continued to evolve, we realize that that's where most practices and so many practices have evolved to really provide comprehensive care for patients, having ODs and MDs all working up to the maximum scope of practice, and allows us to really diversify within the practice to do various areas of specialty.
So speaking of that, I mean, as you said, that at the time when this was coming about, that may have been controversial. So what led to the formation of this company to begin with? And then maybe we could expand on some of the challenges that you may deal with dealing with interspecialties.
Well, the challenges that we had was it just really wasn't accepted at that point. And we had a real bifurcation between optometry and ophthalmology. And a lot of optometrists would look and say when it was time for their patients to have surgery, that patient may never come back to their practice again. That there were full scope ophthalmology practices that once that patient had surgery, they would absorb that patient and they would provide the primary care. And realizing, as I think some of what occurred at that point was decrease in reimbursement. I think the need to be more efficient and do more volume surgeries, and just really let some of the surgeons specialize within that area, and maintain the patients within the primary care practice to provide your annual eye care and provide as a scope of practice continue really to provide a lot of anterior segment as well as some posterior segment diseases that can be treated right within the optometric practices. So I think what it's led is to really people being able to perform maximally instead of the jack of all trade, master of none scenario. It really has allowed individuals to practice really up to their full scope of practice, and the beneficiary to that are the patients.
Absolutely, because it would seem to me that it's an advantage where instead of referring out to a doctor where maybe you've got to go to an appointment on another day, I would imagine in your practice there's a lot of cases where it's like, hey, let's get you over to talk to another doctor that's right here in this facility that we can talk to today.
Well, exactly. And we also really promote with practices referring into us. What we really promote is really carrying that or taking that care to the maximum level, and whether it's getting patients prepared for surgery, taking care of their ocular surface conditions, it really is a matter of us helping the optometric community promote that type of care prior to the referral as well. So not only do we do that within our own practice when we see patients, but we really encourage that with the optometric community is, by putting on continuing education, by really, being there as a resource for those practices to help them provide a higher level of care within the practices. And I think today now more than ever, we need to do that. We need to be able to have those efficiencies because with the decreased reimbursements and then with the pandemic, I think that it's been so overwhelming as the dispensaries have been affected with contact lenses, with spectacles, the ability to see patients. I really do believe now more than ever, you have a choice. You can either see more patients to maintain the financial stability of the practice, or you can do more and provide a higher level of care for the patients that you're seeing. And that's all part of our overall scenario. So, we will provide it within our own practice, but we also encourage that within the optometric practices within our communities. And of course, with me doing a lot of education, I promote that concept throughout the country, is really doing more within your practice.
And one of the things that I think goes into that as far as expanding services is sort of a focus on ocular surface disease, which I know is something that you're passionate about. I know you have lots of roles within the practice, but I know ocular surface disease is one thing that you do focus on. What does that entail for you on an average day?
Well, it really was spawned out of need because we created a very busy, very efficient surgical practice. And as refractive surgery was coming along, what we realized is that those patients, we were exacerbating, in some cases creating and lighting that fuse on ocular surface conditions. So I really became involved to really optimize outcomes and minimize adverse events after a surgery by taking care of ocular surface. So now the majority of my practice is made up of seeing those patients either preoperatively or postoperatively to try to mitigate the effects of the inflammation that comes from the ocular surgery. And really get those patients prepared. So my day is a day that I will see new patients, patients that have been referred to the clinic that haven't previously been treated, patients that have been treated, have had surgery. And then I do receive a lot of referrals from the ophthalmology and optometric community within Northern Nevada for just the stubborn ocular surface conditions that a lot of doctors are saying, okay, I'm kind of at my limit for the procedures that I can perform on this patient, so I'm going to refer to somebody who really specializes within that area. So I see a lot of patients that will come in that have been very frustrated. They've had dry eye and ocular surface condition for years, and now their provider, both optometry and ophthalmology within the community, are saying, okay, we're going to hand you off now to someone that really gets into this subspecialty.
So talk to me a little bit about when you're getting these referrals, or even somebody that comes into your office directly, like what are the protocols? How do you go through troubleshooting these issues? Are they similar? Is every case different, or is there a protocol that you go through on every single case?
Yes, all of them. they're all different. They're all similar. They have their nuances on that. So, of course, the most important thing is a case history. Just like any disease entity, you really have to find out what the patient's been experiencing. So we start out with a good case history. Then we also use a questionnaire. Since we're looking at ocular surface conditions, we want to use the SPEED questionnaire, DEQ-5. One of those questionnaires within the practice. Typically, we're using a SPEED questionnaire. We want to know the symptoms that the patient is actually experiencing. Then we go ahead, since they're in my specialty clinic, we do mybography on every patient. I need to take a look at the structure of those meibomian glands, because shortly after that, I'm going to be looking at the function of those meibomian glands and to see how they look. And of course, while you're doing that, you're expressing the lids diagnostically. You're looking at the anterior blepharitis. And as you're doing this on each patient, really you just start clicking away in terms of the type of treatment that patient, and now you're trying to prioritize that. So it's similar in that a lot of patients will get a supplement, they'll get a warm compress. They will typically get one of the anti-inflammatory dry eye drugs, but now you're starting to build on, okay, what do we prioritize? We start that patient out, and this is where everything starts to differentiate. Do they also have an epithelial basement membrane dystrophy that's giving them similar symptoms? So I take a look at that patient. My staff does. They're very well trained to look at these areas. And then that's where I developed the treatment plan. So while there's a lot of similarities, there's a lot of differences, but by and large, a lot of these patients are going to be on a base treatment just to get going, because that's their physiology. That's what they gravitate toward. And some patients will say, well, do I have to be on this forever? Well, it's like that hypertensive patient or that patient with hyperlipidemia. Yeah, they're going to have to make some type of a modification in either the treatment they have or their diet and their exercise otherwise they are going to be on that forever. And more so with ocular surface disease, there's a lot fewer things we can modify to really give that patient comfort. And I mean, and we're living part of that in the moment, and that is this digital world we're in, just causing so much strain on somebody.
When you're treating patients, is there a most common affliction? Is there something that you find happens the most often when it comes to ocular surface disease?
Well, it's that, yeah, there is. And a lot of it will look the same, and you have to really get down to the base etiology. But when you're looking at this, you're realizing that, as we have tried to silo in the past, and we're saying, well, is it aqueous deficient patient? Is it an evaporative patient? That in my experience, through looking at this over, the past 20 plus years in ocular surface, is that it's a continuum, and that different people physiologically progress at a different rate, and whether it's meibomian glands or whether it's aqueous deficiency. And what I would always point to is take a look at the Sjogren's patient, which is the consummate aqueous deficient patient. And you never see a Sjogren's patient with good meibomian glands. So that during that whole continuum, patients will hit at certain areas and develop a little sooner. But since we really put a focus in looking at the meibomian glands, now we realize that in that continuum, a lot of patients have that. Some are more advanced, some are just beginning, and you can offer a lot of help. So I think we're really gravitating toward procedures at this point to help patients also. So not only just cover up the inflammation, but really address the root causes of the inflammation. And in the case of the lid diseases, we need to look at that anterior blepharitis. We need to look at the staph buildup, the biofilm buildup, and we need to look at then the obstruction that causes. So sometimes you're digging a little deeper from a procedural standpoint.
Well, and that makes a lot of sense. I mean, obviously, certain things will all present the same, but the underlying affliction may be different.
Yeah, and of course, then you really get into with the case history. You're really looking at those autoimmune afflictions that patients are going to have, and especially in the patient base that I see, that are more advanced. People have been treating and still have a very symptomatic patient that will really look at the systemic history as well, trying to figure some of that out. And some of that is just, that's going to be there, and we just have to deal with it. And people will say, well, why do you test for Sjogren's? You're not going to treat any differently. Well, yeah, we really will. First of all, we need to know, and we get a lot more aggressive a lot quicker, and have to stay that course. And the emphasis that you put on the patient is going to be much greater as well.
Absolutely, that makes a lot of sense too. You always want to find out exactly where this is coming from, not just the symptom, but the root cause. When you're going through these patients, do you find protocols that you recommend on every patient? Is there something that's sort of a baseline that you always start with, or again, is that different for every person? For instance, a second ago you were talking about procedures, other things like that. Do you find that there's certain procedures or certain products that you're always using?
Yeah, there really is. There seems to be a baseline that's going to affect everybody and be beneficial to everybody. And that really, there's such an inflammatory type of diet in the United States at this point, that putting on an anti-inflammatory supplement is going to be very beneficial for the vast majority. So right away, you're checking to make sure patients aren't on any kind of a anticoagulant. And if they aren't, then most of the patients, I'd say the vast majority, 95+% are then going to receive a supplement. And that's just going to be something that, because they gravitate toward inflammation in the ocular tissues, that really they need some help with that. So that's going to be a lifetime type of treatment for a patient, is getting them on an ocular supplement. And what I tell patients is, I'm going to start out really aggressive. I'm going to get a hold of this because it's chronic, it's progressive. And first of all, we want to stop the progression. Then we want to back it up as much as we possibly can. And then I'm going to have you on a treatment that is going to be the minimum treatment that is going to prevent you from progressing. And they say, what will that be? And I say, I have no idea right now until we get there. But I'm going to start out pretty aggressive. I'm going to give you a lot of homework. I'm going to give you a lot of things to do, but it's because there's a condition here that is really rapidly advancing and giving you symptoms and hurting you in your occupation, your avocation. And so we want to stop that. We want to back it up, and then we'll control it. And so, and that's why, I think my biography is so important, because I'm telling these patients, we're going to have to, at some point, this isn't going to be the first priority, but we're going to have to take care of these lids. In so many patients, we know that just by looking at the structure and the function of the meibum and the meibomian glands, that it's a chronic problem that's going to continue to progress. And we see that with the tear breakup time being so rapid, and individuals, and they'll tell you, the computer is a great thing for a diagnostic. Also, how do you feel after you've been on a computer for 4 or 5 hours? And patients will then say, my problem really gets a lot worse. So, but there are some common warm compresses I think are really good. And those are really just real baseline, real basics, because we say we have a problem, we have occlusion in the meibomian glands, we have inflammation in the surface. And then of course, one of the most important things that is common for everybody is a palliative tear. You want to be able to give them comfort. And when they gravitate and they go into that wall of tears in the grocery store, in the pharmacy, it's absolutely overwhelming for those patients. So you want to direct them, you want to specifically give it. And that's why I really promote making that available to the patient at the point that you're giving the care, that they walk out with the proper product in their hand. And my whole motivation for initially doing that within my practice was not to increase sales, was not really profit. It was for compliance, and that they were going to hold me responsible. If I said, you need to use an artificial tear 3 or 4 times a day, and they just went out and found a tear that was loaded full of preservatives and they had the wrong type, then they weren't going to get the benefit, but they were still going to hold me accountable because I told them. So I want them specifically to have the tear that I'm really recommending.
Well, Dr. Devries, thank you so much for being with us today. It's always a pleasure to get a chance to talk to you, and I hope we'll get to speak again real soon.
All righty, Thomas. Thank you.
Thank you.